Hello, everybody. Welcome to a lecture about power, emancipatory knowing, and change. We're going to start with a discussion about power. So, what actually is power? Well, we're going to use the definition here that it's the ability to get things done, to mobilize resources, to get and use whatever it is that that person needs for the goal he or she is attempting to meet. So, if we think of somebody that is in charge of a club at a school and they decide that they need a room. Do they have the ability to get that room? Are they able to mobilize resources? Let's say they're doing this as a part of a school project. It's a club at a school. Are they able to access the administrators and say, can we have a room? Can we have the lights on? Are they able to get whatever it is that that group needs for the club, for whatever that leader of that club is trying to meet? So think of it in that way. It's just an example. There are obviously negatives to having power. We sort of think of people who are power hungry in a negative way, that it's about having control, about influencing or having domination over someone or something else. But there are positive sides to it as well. It's an infinite force to help to establish the possibility that people can free themselves. So we talk about power and empowerment, and that's the positive side of having power. So what happens when nurses have no perceived power? Now, clearly every individual has power, and if we have a problem where we're not able to mobilize resources to get things done, to meet our own goals and needs, there are usually reasons that we've given away that power for whatever reason. And so that's why we call it perceived power. And so nurses with less perceived power, so they're not able to get their needs met, they're not able to make change. They have less job satisfaction. There's more distancing of themselves from their patients and their coworkers, which clearly would interact with more burnout and more job dissatisfaction. They are less likely to help patients also feel empowered themselves, and partially because they don't know how to do that for themselves, and so it's hard to help others to do that as well. And they actually have worse patient outcomes throughout the literature. So two big barriers to this. There's a question about levels of entry. We, as you know, as RN to BS students, we have a question about level of entry. There's diploma level, there's the baccalaureate level, there's the associate level, and yet we're all nurses. We're all RNs, and so we take the same exam, we get paid the same amount of money, but there is, and at least has been, a lot of internal fighting of should there be one standardized level of entry, what should it be? We haven't been able to decide that for themselves, which is why you see now that the market has changed. The hospitals, the individual hospitals, are making the change of we're just going to choose baccalaureate level of entry because that's what we're going to choose. There are multiple roles then for nurses of what they can do across levels of entry. Same pay for a different preparation, that causes a problem. The political influence can be different. And certainly lots of public confusion over what's a nurse, what can they do, what can they not do, why are some getting different levels of education, and what does that mean? We can look at gender roles as a cause for why nurses sometimes have such a loss or a sense of a loss of power. Nurses in general, when it comes to women, are reluctant to discuss power. Women don't usually like to discuss that. We're socialized to not exert power. Nurses are very gendered as a profession. So in other words, even though we have men in the profession, it tends to be a feminized profession. So we talk about things like altruism, helping, and caring, and those are not power-driven characteristics. So as a profession, even if it's a man that's involved in a situation, it tends to then be labeled in the gendered role way of not power-driven profession. And lastly, there's a reluctance to acknowledge and to use one's power. Again, partially, if you have people that are socialized to not exert that power, then it makes it very difficult for one to then step forward instead and use the power that they actually have. So 3 areas where nurses really have power. We have control over the content of our practice. And I can tell you, you're going to see these 3 things again on an exam. So put a big star on this one. Look at this, a star. So the control over the content of practice. So we have autonomous practice. Basically, you get your assignment in the morning, you go out, you do your job, you come back. You don't have somebody that's really watching over you. And yes, we have standards of practice, but there's a whole lot of weird stuff that you could do, not assessing people, writing stuff down that didn't happen, that no one really knows about until something bad happens. And that's really just because we have a very autonomous practice. We do define our area of expertise. We raise a lot of influence. And this counterclockwise it rounds refers to, for those of you who do interdisciplinary rounds, and I mean rounds that aren't just with the case manager about when a patient's going to be discharged. In this example of rounds, if you start with the other side of the table, the respiratory therapist will talk about how the patient's doing with their breathing treatments and using their nebulizer, and their maybe you're doing teaching about how to use a spacer. And then you have somebody from social work go and talk about how the family came in and they were talking about these problems. And then you have somebody that's the physical therapist talk about how they got out of bed to the chair today and they tolerated it pretty well and they were able to sit up through lunch, blah blah blah. And then when they get to the nurse doesn't have anything to say, because all of those, as we discussed last week, all of those professions came out of nursing. And so what ends up happening is if you reverse the direction of the discussion, it rounds. So then instead of having the nurse go last, the nurse goes first. The nurse will talk about how the patient's doing with their breathing treatments. The nurse will talk about how the patient did sitting out of bed with a chair, and the nurse will talk about how they're tolerating their advancing diet. The nurse is in control of all of those things, and so it's a matter of perception of being able to define what our profession does. Part of that is the autonomous practice piece. So having control over the context of practice has to do with a much bigger picture. It establishes the environment in which you practice. So if you think of sort of the culture of the unit or of the hospital, so any of those hospitals that are looking to go towards magnet status, they're creating an environment of that workplace. And so that's the context of practice. So the control over the competence of practice is, for example, that there's multiple levels of entry, lower practice level than other professions. And so again, we talk sort of about that perception piece of, we as a profession establish what our level of competence is. At some point we could say, and in the state of Connecticut this sort of just happened naturally, we could say that diploma nurses are a thing that we don't have. And again, that has happened rather naturally now that the last of the diploma schools in the state of Connecticut will be closing, I believe, this year. And then after that, they're all going to go to University of Bridgeport and be baccalaureate prepared nurses out of that same program now instead of diploma. And so we won't be making any more diploma nurses, but we certainly still have them in the profession. But we as a profession have control over then what defines us, what is the NCLEX exam, and why is this a lower practice level than at other professions? So you think of physical therapy. Physical therapy, as we've said before, came out of nursing, and yet they're a doctoral level of practice, and that's a standardized thing. Somebody who's a registered dietitian can come out with a bachelor's degree, but then I believe it's in with 3 to 5 years they have to have a master's degree. Same thing like with teachers. Teachers can come out with a bachelor's degree, but within 5 years they have to have a master's degree. So why don't we have that in nursing? Why not say you have an associate's degree and that's fine, you're an RN, and in the state of Connecticut you have to go back to school and get your bachelor's degree within 3 years. We could do that. That's for nursing as a profession to decide that. And that's our control that we have over the competence of our practice. It's just a matter of actually utilizing that power that we have. So the ways of knowing, and I'm just going to briefly get into this. When you take Nursing 423, that's your nursing theories class. We're going to talk a great deal about this, and then I'll be able to say, remember when you took 407 and we talked about the different ways of knowing. But I will start off by saying that there are 5 ways of knowing. We have ethical knowing, which is certainly talking about ethics, empirical knowing, which is the science of nursing, existential knowing, also called personal knowing, and the aesthetic, which is the art of knowing. The last of the 5 is emancipatory knowing. Now, this nursing theory was started by Peggy Chin and Winona Kramer. Emancipatory knowing basically addresses the social and political context of nursing and includes the 4 other patterns that we just talked about right here. So it recognizes serious social barriers to health and well-being and requires an understanding of sort of the nature of knowledge and really critiques what's going on in the workplace. So when you may have somebody, let's say we're talking about a slow code. So somebody that's 102 years old, the family wants them to be a full code. They are not conscious, they have poor quality of life. There's this concept of a slow code, which is that you go and you have a code because the family wants you to, but maybe everyone responds really slowly and doesn't do things as quickly as they could, so that the patient's allowed to naturally die, even though they're a full code. So there's this concept of a slow code. There's all kinds of ethical implications of that. And so we would have to use our ethical knowing, our empirical knowing, our personal knowing. Do we have that happen before? What happened with the family? But in this case, if we were talking about emancipatory knowing, we may say, well, maybe it's a lower level of education, or maybe it's spiritual beliefs. Maybe it's this, maybe it's that, of looking at the reasons for social and political and really cultural reasons that there are issues in nursing or in nursing practice and in healthcare. So emancipatory knowing begins that conversation so that we can look at that. So it's about noticing that there's an injustice, asking why injustices are invisible and unnoticed, and identifying ways to right those social wrongs. And those are things that the nurses can do and have the power to be able to do. So where is the power in the workplace? So who has the power? If it's not the nurses, who has it? It might be the administrators. It might be family members. We might perceive that they're the ones that control practice. We might say it's the physicians or somebody else altogether. There are healthcare structures that maybe prevent nurse empowerment. So there, for example, I'll use an example of someplace that I used to work. So nurses are allowed to give patients showers. In some hospitals, we can say as long as the patient is ambulatory, the nurse can of course go ahead and give the patient a shower. In other places where I've worked, they have to have a physician written order to be able to put the patient in a shower. Now that's silly because we don't really need permission to give our patient a shower. It's within our scope of practice to do so, as long as, again, it's safe to do so because they're up and allowed to be ambulatory. And so by taking away that ability, it means that now the nurses all have to rely on somebody else to let them do what they know is actually in their scope of practice. And so bye-bye some of the power. There may be a nurse manager who doesn't want to hear about a nurse that's in a nursing school program like you guys all are, and maybe brings a really interesting article and says, hey, maybe we could try something like this here. And if there's not support from administration, then it'll be really hard to enact change in that way. Is this true of all healthcare professionals? Is there this kind of resistance to what's going on or what the nurses are asking for, to raising questions about problems? So nursing advocacy is actually a specialty in nursing. Nursing advocacy focuses on individuals and individual communities. There are social structural changes, and that can make change for everyone. So this level of advocacy is really about having a healthy society, although again we have these individuals, but it's really about helping the greater good. So I'll give you an example. So Miss Doe has diabetes. She's overweight and is having trouble controlling her diabetes. She owns her own restaurant and lives in an apartment above it, but the neighborhood is unsafe, and so she asks you for your guidance. So give examples of your nursing knowledge. So you could talk about the empirics, you could talk about the science of it and what you know about diabetes. You could talk about the ethical concerns. You could talk about her in terms of what type of care she has. She owns her own restaurant, so that may mean that she has poor health insurance coverage because she has to pay for it herself. The personal knowing, well, I don't know. I just started working with Miss Doe, but last week I worked with somebody else. Miss Doe is Vietnamese, and so I have worked with Vietnamese patients before, and what can I pull from that? What is my art of nursing? How can I seamlessly continue to have communication and to move around in the patient's room in a way that makes her feel safe and cared for? And then, of course, the emancipatory knowing part. So she feels like her neighborhood is unsafe. And I've noticed that I've had a lot of patients that feel unsafe walking in their neighborhood, and Mrs. Doe needs to be able to have more exercise in her life. And so, what are we doing to help her? Maybe I know of a way that we could get an indoor walking space, or we could start a neighborhood watch, or there are enact with the community engagement of what's going on in Mrs. Doe's neighborhood. So there's a variety of things we can do, and all of those would be appropriate actions for a nurse to be able to take out.